Usually in pediatric postings, we get 1 or 2 sessions on newborn examination. And even then, it's more about neonatal reflexes because everything else is irrelevant. Or it gets kind of pushed lower down in the pecking order. Now, but when we come to real life, what happens is this. I just want a couple of you to just answer, drop in the chat box your opinion about this. What do you see? I mean, whatever you just see, if you can just put it in the thing just for the next 10 seconds.
We see newborn baby.
Sir.
With the face, hand, and also the legs. Okay, and also a couple looking at Tiroumourougane's
beautiful lake. Yes, sir. So it depends upon what we want to see. I mean, you could see this nature, you can see the trees, and you can see the couple, and you can see the lake, or you can, of course, see the newborn baby. And that's what happens when we talk about a neonatal examination, because whenever we are taught about the newborn examination, it's overwhelming, and there are a lot of things to look at. And unfortunately, when we really do in life, we often get called in a resuscitation scenario, particularly after in the cesarean section, and then where we are told to say the baby is all right, and can we go ahead with the sterilization. I mean, it's one of the most difficult jobs for any person, a neonatologist or pediatrician, to say the baby is normal or not abnormal. And probably that's one area where, and we got hardly given few minutes. By the time the obstetrician finishes off the uterine switches, she wants to tell us if the baby is okay or not. And so that's probably one area where we need to stick with our newborn examination, try to come to a conclusion within a matter of a couple of minutes. And the next one we need to do is within 24 hours. Imagine most of our places, particularly in the many places where they're delivering easily 10-15 babies in a day, and trying to examine each and every one of them in the detailed manner, it takes forever. So within the very limited time available, we need to somehow come to a conclusion if the baby is okay or not. And of course, again, prior to discharge. So we need to make sure that the baby is fit enough to go home, and there are no obvious danger signs, so that we don't want the mother to bring back a baby who is sick or even dead. So these are 3 probable instances where we could think of newborn examination in a focused manner, where we need to, it's more about being up to the point rather than looking at everything. So what are the prerequisites for examining a baby? First and the most important, there are triple E's. So let me start with the first E, which is environment. We basically need a warm room. A baby who is in a cold room with a nice AC on is just going to scream down the place, and we are not going to get findings very well. Obviously, the room has to be very well lit, preferably natural light. If not, at least even with the artificial lighting, a good well lit natural light, white light is very important. Again, we don't want everyone screaming because we will not be able to complete our examination properly. And last but not the least is that the environment where the baby is placed should be warm. So the next bit is, what are things which we need? Definitely we need a watch with seconds to observe the respiration, heart rate. We need a good stethoscope. I still remember the times when our professor Dr. Srinivasan used to force us to buy a Litman, without which we couldn't enter the pediatric ward. And the ophthalmoscope, of course. We need a good ophthalmoscope. I just wonder how many of us really carry one, and a good torchlight. But last but not the least would be ourselves as examiners. If you really look at it, we need to think about having at least 3 to 5 minutes for examining a newborn baby. That's a bare minimum we really need to examine the baby. And we should be prepared to have a proper hand hygiene. Even if you cannot wash hands with each baby, at least we should be able to willing to use a alcohol drop. So once we are ready, we will go about examining the babies based on certain basic principles. It's not like inspection, palpation, or percussion, or auscultation like older babies. It's slightly little bit different. And no history is relevant, no examination is relevant unless we have a proper history. Now, given the over the years, what I've learned is, yes, it's important to ask, but what is more important is to check the records. Okay, yes, you talk to the mother, you find out, you can talk to the obstetric colleagues and then find out, but there are innumerable times when we have been stumped when we look at the records. So never forget to go through the case sheet before you actually touch the baby. And when we look at the examination itself, we have to look at, we need to follow these three dictums. Always look, listen a little bit, and feel even lesser. Now, this is different from what we are always taught, but this is going to be more productive if you follow this. So let's start with examining the baby soon after birth. What is my objective when I do this? All I care about is to find out if the child has got any critical or disconcerting anomaly. I need to make sure that the baby's cardiopulmonary status is okay and there are no major congenital malformations. It's really worse if we miss, let's say, a major anomaly like a cleft palate or a genital abnormality or let us say analepsia. Say everything is okay, come back after an hour to find that the baby is having all these problems, and then we cutting a sorry figure. All the points which we are going to look at in a newborn, the importance of which varies based on the gestation age. So it's very important to have an accurate gestation age. And always remember about whether the baby is appropriate for gestation, large for gestation, or small for gestation. Now, very often we come across another terminology called as IUGR, or nowadays moved on as fetal growth restriction. Now, please remember that fetal growth restriction and SGAs are not the same. Fetal growth restriction basically means that we have got a baby who is less than optimal, who has had less than optimal growth intrauterine over a period of time. So you could have small babies who are not fetal growth restricted, or vice versa. You could have normal appropriate size babies who are fetal growth restricted. So what would I like to ask in the history? Yes, there's a huge list we can ask, but probably these are the bare minimum which I personally would like to ask. One would be, is the mother maternal, is she a diabetic or not? What about the liker status? That's going to give me a lot of information. What is the maternal age? Of course, older the mother, the more likely to problems in the babies. And what is the presentation? Like if you can have a baby with breech, you might have, they are more likely to have a dislocation of hip and so on and so forth. So probably these are the bare minimum history I would like to know beyond within the available time. So once the baby is stable enough, I have resisted, these are the things I would like to look at. Always look at the heart rate. Now, we are all taught in our NRP programs to concentrate a lot on bradycardias. So whenever the heart rate is less than 100, we want to support the respiration. When it's less than 60, we want to support the cardiac status. But what we don't remember very often is that tachycardia is as much important as bradycardia. So if a baby is going to have sustained tachycardia, look for a reason, and very often it is respiratory. So the baby might have some grunting or might have some difficulty in breathing, and along with that you get a tachycardia, or maybe it's in a bit of early shock, and which we can easily miss. So do not forget the tachycardia. Of course, we need to look at the respiratory effort, and as Dr. Srinivas said, we can look at Silverman score as a useful measure, or there are very simple ways of doing it, which we'll look at in the coming slides. Now, most of us are taught to look at color. I mean, we are told as RHC, so as color. But what we need to realize is that our eyes lie. Our eyes are just not good enough to figure out if the child is hypoxic or not. In fact, if you remember, a baby looks pink even once the saturation is above 85%. So if you really want to identify a baby who is who is hypoxic, we need a pulse oximeter. And the ideal pulse oximeter is the one which has got a signal extraction technology. The digital technology very often is not very accurate in picking up the saturation. Now, If you are in a situation where you don't have a pulse oximeter, another useful measure is a tone. I would probably even say this as a poor man's monitor for yeah, the the cardiovascular status. So a baby who has got a good flex tone, who is pink, who is having normal respiration and normal heart rate, is definitely having a normal cardiovascular stability. And of course, how he is reacting. Okay, let it be a cry, let it be sneezing, let it be a response to a suction catheter, all this matters. So all this you could just do by having a basic look and making sure that the baby is fit enough for undergoing further examination. Okay, so we are taking care of the primary most important to make sure the baby is alive and well, and then now let's move on. So what are things I will look at? This is all about a quick screening for malformations. I'm not going to do a detailed examination. So basically I start from the top to bottom, midline to the back. So what do I start? I will start with the head, look for any obvious dysmorphic features. Again, I will talk about in detail in the subsequent slides. Look for asymmetry of movements of the face. You can, particularly if the baby has undergone an instrumental or forceps delivery. Now, very often we want to check for esophageal patency. So what do? We tend to put an nasogastric tube or orogastric tube and then make sure that there is esophageal patency. This is a practice which probably has to be abandoned for multiple reasons. The most important reason is that we can injure the esophagus or the stomach. That's number one. Number two is that very often the catheters can coil within the dilated esophagus and it will appear as though we have got a patent esophagus. In reality, it's not the case. So what else we can do? All we can do is to look for pooling of secretions. If you remember, all the fluid is coming out of the lung. Part of it gets absorbed, but a huge amount is still coming out of the lung into the oropharynx. And that has to be absorbed through they go down the GIT. And if there is a block somewhere down there, it is going to get pulled. So if you get a lot of excessive pooling of secretions, then we need to think about a esophageal atresia. Now, cleft palate is something which is often missed. Now, the best way to look for is, again, there is a lot of debate, but you can easily look into it and see there is cleft. But if in the case of submucous cleft, the only way to figure out is to feel the palate and then find if there is a cleft palate or not. Now, looking into the eyes is a bit difficult in soon after birth because the babies tend to close their eyes quite a bit. And but it is important, particularly in the scenario where we need to go ahead for a sterilization. And of course, ears are something which is fairly obvious. We are going to look at and then see if there's deformity. The next bit we need to look at. So we have finished the head, come to the chest, look at if there is any obvious signs of increased work of breathing, that is chest retractions, flaring, or increased work of Alanisate. And then we go down and then look at the abdomen. And there is one anomaly which we can miss all through our life. We don't figure out right after delivery that is a single umbilical artery. Given that nowadays a lot of mothers have very good ultrasounds antenatally, it is quite which picks up a lot of congenital anomalies. Probably is of less importance, but it's still useful finding to pick up. Now we talked about esophageal atresia. The next one I would look at would be the anal atresia, the anorectal malformations. Please remember, when we are looking at the anal opening, we need to just not look at only the opening, but also where it is located. Now, very often we are happy to stick a catheter and then look for and then claim that the anus is patent. It is a practice which should not be done because most cases of anorectal anomalies can just be obvious just by looking at it. And sticking up a catheter is more likely to cause a rectal perforation than to establish clearly the absence or presence of a anal atresia. Last but not the least is looking at the genitalia in the abdomen. This I'm talking about the abdominal examination. This is something we have to be very careful, and let's not be in a haste to assign a sex for the baby. If we are not sure, it is better to take some time and declare later on rather than other way around, because that's one which gives a lot of problems. And then move on to the limbs. I said top to bottom and then front to back. So look for the asymmetry and look for any obvious anomalies. It's not going to take much time. And again, when you look at the back, look for spina bifida. All this looks very simple and intuitive, but the problem is that over the years, definitely we have come across a lot of patients who are missed fighting. I've seen babies at 2 months with a large cleft being missed. I've seen babies with at 1 year with the spina bifida being missed and so on. So keep that in mind. So having looked at the baby, then let's learn to listen for the baby. So listen to the cry. If the cry is vigorous and happy, I'm very happy. If the cry is weak, I'm worried, and definitely if it's forced, I'm not at all happy. And look for abnormal sounds, particularly grunting. And finally, get a stethoscope and listen to the heart sounds. Instead of looking for murmurs are probably not important, but they don't give a lot of information the first 24 to 48 hours. But it's more important to listen to which side it's heard, better on the right or the left side. Again, my teacher has really emphasized this important on me as a student. So yes, I need to. And then move on to feel. Okay, there is a little mnemonic if you want, you can remember. But what are things you need to feel? You need to feel about 7 things and nothing else. Most important is the femoral pulse. One of the pulses which are just not given due importance, but it can give you so much information. A weak pulse, think of heart disease, think of shock. It is very, very important. And then look for a capillary refill time, again to suggest how well this child is perfusing. And never to forget to palpate the abdomen in a newborn period. I mean, soon after the birth. So you can always miss a big tumor or a renal mass and then find it difficult to explain later on. Genitalia, yes, not only look but also feel, particularly for the testes in a male baby, to make sure that it is descended. And another point, another atresia which everybody likes is the coronal atresia. We again like to put a tube down the nose and then look for. But please remember, a coronal atresia, a unilateral coronal atresia, will not pick it up by just putting a tube down the nose. And bilateral coronal atresia is easily picked up with the pulse oximeter. If the baby closes the mouth, the baby is going to, saturations are going to drop. If he's going to be screaming, the saturation is going to be normal. So easy way to pick up rather than trying to put a tube in both the noses. Last but not the least, hip dislocation. Usually I don't do it, I must admit, but it is something worthwhile doing because it's a major condition to be diagnosed soon after birth. Once we have done all this, just make sure that any other finding which we have picked up on inspection, confirm it, and then we can go about and then see. Just a couple of words about pulse oximetry. See, in the ideal world, we like one of these, the signal extraction technology pulse oximeters. I mean, right now it's mainly the proprietary with Massimo, but expensive. Right now it's close to 70,000-80,000. So there is another option which is Indian made by the IIT Chennai, along with its startup from IIT, which is worth trying. So let's go on. This costs less than 7,000 and it's quite useful, can be used in a neonatal period. And as you can see, we are just using it on newborn. And it's fairly accurate. In fact, I've compared it with both. So it's something which you can consider, made by the company Elixir, but it's an IIT Madras startup. So moving on. And that's at the end of this, you can say if the baby is okay or not. You can say if there any obvious life-threatening or gross anomalies or not, and then move on. And then once we have done that, we always come back after about 24 hours and then re-examine the baby. Now, the objective of this is to say if the baby is normal or abnormal. Again, going back on the history, we have already, whatever we did in the first set, we need to look at again. But there are a couple more we need to look at. But one is to ask the mother about the activity of the baby. Ask her if the baby is crying, if the baby is feeding, has he passed meconium, has he passed urine, and are there any other problems she would like to report? And that is something which is very useful. And then again, never to forget to check the gestational age, the weight of the baby, how much weight loss has been there, and what is the temperature. Summer babies get too hot, winter babies get too cold. And the worst is in summer babies do get cold, particularly if they are in a AC room. And the same stuff about looking at the cardiovascular stability, whatever we have discussed, and then move on. See, early on when we soon after birth, we just screened through. We didn't spend a lot of time because our time was limited. But here we spend a bit more time, look at carefully, but really examine the baby from top to bottom. So the first thing we need to look, it's all about look, look, look. Please remember, look is far more important than listen, which is far more important than feel. So start with the skin color. If the baby is pink, maybe with the blue peripheries, that's fine. I mean, you can have acrocyanosis, it's very much physiological and normal. If the baby looks pale, it could be mean that baby is in shock or is in anemic. Yellow babies, particularly within first 24 hours, is always a danger sign, and we are trouble. If the baby looks with cyanos or with blue, obviously cyanosis, again something to worry about. So that one single finding is going to govern everything else. We don't need to go through the whole lot like the long case and then come back to say this child is having a problem. Of course, there are going to be focal changes in the skin or discoloration. Some of them are physiological, some of them are pathological, but self-resolving, and some of them are definitely pathological in worry. Okay, so looking at it, we can have something like a milia, few changes, peripheral cyanosis, like you can see the cyanosis around the nose, and sometimes even petechiae. Very often neonates can, though it can be abnormal, it can very often it's normal, particularly in babies who are born vaginally. You can have a major bruising. Yes, it's a pathological finding, but it will resolve over a few days' time. Peeling of skin is another physiological finding, or of forceps bruising. So once we have looked at the skin and made sure we are happy with it, we move on and look at the posture of the baby. Okay, and all we need to look at is his movements are symmetrical or not, if there is good flexion at the upper and the lower limbs. And again, it is to be correlated with the gestational age. Presence of cortical thumb at any age is abnormal. And if there is asymmetry, either of the face or of the limbs, we need to be worried about. And having looked at the color, I've looked at the posture, I've just moved on to the head. Okay. So look at, very often you might see a bit of molding. Others are worried. You just need to, so you can see here that it's basically one bone sitting on top of the other. You can see the ridge, and that is fine. Or sometimes you might see a caput as well, diffuse swelling. We are happy with it. And sometimes this might be capsulohematoma. I'll come to how to differentiate with the two in the field. Now, I promise that we'll discuss a little bit more about how to look for dysmorphic features. Again, something which we are repeatedly taught, look for dysmorphic features. Or we assume that, okay, it looks like a Down syndrome, or it looks like one of the other syndromes. That's what we look at. So what are things we need to look at? There are 7 different points we need to look at. One is to look at the orbital placement. See how close or how far the eyes, the orbits are. Second is, what is the palpable fissure length? Okay, is it too narrow or too big? Again, there are criteria for this, but for most of us, we can look at it and then we can think, is it too small or too big? And then what is the slant of the palpable fissure? And are there any epicanthal folds or not? If there is any, sorry, got mixed up. If there are any midfacial hypoplasia, in other words, it's going to be a flat, depressed nasal bridge. Okay, what is the shape of the philtrum? And finally, what is the ear placement? Do we have low set ears or normal ears? Once we have done that, get the baby to open the mouth. All we need to do is just put the finger on the upper or lower lip, and they will happily open the mouth. And you can see, very often see a natal teeth. Sometimes you can see a cleft, which can easily be visualized with the torch. And always look for a tongue tie, not because they create a problem, but it causes a lot of anxiety. Unless it's really one of those grade 4 tongue ties which are stuck to the base of the floor of the tongue, floor. Everything, most tongue ties don't create trouble. And then look at the neck, see for any excess webbing or drag goiter. I've never seen one in the life. And then look for the increased work of breathing. So you can look for 3 things: a tachypnic baby, a baby with severe chest retractions, and you can, as you can see, you can the head bobbing, and then the alar nasal flap. And then move down to the abdomen. Look for any obvious scaphoid abdomen or a distended abdomen, or sometimes you might see a gastric abdominal wall defect. That's all. I only care about findings which are going to tell me if the baby is going to be normal or abnormal. It's very important to examine the look at the genitalia cavity and try to decide is it male or female genitalia. and there are any obvious problems with it. And as said, anal patency is fairly easy to look at. All you need to do is look at the presence of, in any case with anorectal malformation, you will not find the anorectal sphincter. The absence of a anal sphincter itself would suggest to us that the anal patency is just not there. And then come to the peripheries, look at the limbs again, see if there is any asymmetry or if there is any abnormalities, particularly if there is any polydactyly or syndactyly or any fractures. And then go back to the back to look for the spina bifida or any swelling or any tufts of hair or those. So now I have looked at the baby, and now I will move on to listen to the baby. Again, listen to the cry. Such a wonderful way for the baby to tell us that they are all right or they're not all right. Grunting and heart sounds. Now, apart from this, at this juncture, I would like to hear about the murmur also. But please remember, when we listen, most murmurs are a very, very common finding in a neonate. There are a lot of reasons why we have a murmur, but very rarely they're associated with this significant heart. In fact, most critical heart diseases are rarely associated with the murmur. So murmurs, though they are exciting and alarming, they rarely are as important as your cardiopulmonary stability, your femorals, or your workout breathing. So keep that in mind while listening for a murmur. Said we look for and then we move on to feel the baby. So we have just looked at it, and now we just want to feel the baby. Again, we can feel the molding, feel the anterior fontanel, posterior fontanel, and then if you get a swelling, how will you differentiate between a caput and cephalohematoma? All you need to do is try to depress the swelling, and then just see. If the swelling is clearly depressed and it does not refill immediately, it's a caput. If not, it's a cephalohematoma. And then move on. So whatever we told right in the initial examination was good, except we have added one more, which is jaundice. Okay. Now, how will we look for jaundice? Always try to look for the jaundice in the clear light, so well lit place, and with the skin blanched. It's really important to look for the jaundice only when the skin is blanched. Otherwise, it's very difficult to look for a yellowish discoloration, particularly in our Indian babies who are dark colored. And then femorals, never ever forget femorals. You get some fantastic diagnosis just by feeding the femorals. Capillary refill time, once again, abdomen, genitalia, and in a genitalia, always feel for the testes. I mean, it's so sad to find so many boys, undescended testes in the boys being missed. They're coming at 2 years, 3 years with undescended testes when already the damage has happened. As said, colon atresia, think of pulse oximeter, and last but not the least is hip dislocation. So for the hip dislocation, couple of words. So we got 2 tests to do. One is a Barlow's test, which basically looks at the ability by us to dislocate the hip. So and always remember that you need to do only one side at a time and not both sides, because then if we try to do it both the sides, we can break the femur. And the other one is orthodontist, which is testing for the ability for the dislocated hip to be relocated. And next is, as said, most of us don't carry a ophthalmoscope. So, but at least we can carry a torch, open the eyes, and then just see. This was a baby who was just born with us. I mean, he landed up having a congenital glaucoma. All we had to do is just open his eyes to see that he's got severe corneal clouding at birth. So, and even a cataracts can easily be seen if you can shine the torch at an angle and not right at the eye directly. At 90 degrees, if you shine, you will not see it. But at a 45 degrees or even at 30 degrees, you can even identify a cataract. But the ideal way of doing is to look at the red reflex through an ophthalmoscope. So what we basically need is a reflex which is bright red, and anything except red is not acceptable. Always then move on to feel the clavicle and the humerus. Okay, very often we get missed clavicular fracture, particularly with the difficult delivery. Last one, which I probably do, would be the Morris reflex. This probably might be the only reflex I like to do among all the gamut of neonatal reflexes. Just not in my focused examination. So I have done all this, and then I have decided that my baby is okay, everything is all right. And is it okay to let go the baby and not come back and have a look at him? And the answer is no. always remember that just before the baby goes, we need to do a discharge examination. And this is the objective of this is to make sure that there are no danger signs. The baby is fit and ready to go home. Again, history, same stuff. And then cardiopulmonary stability. And the other couple of things we need to look at is there any obvious discharge from the eye, there is any discharge from the umbilicus. We don't want to miss umbilical sepsis and baby coming back with the major septicemia. And then the one thing I will always like to listen is to look for the auscultate the heart again for a new sudden appearance of a murmur. In which case we can do a hyperoxia test and we can just do a pulse oximeter screening and then find out if the baby is okay or not. And then you feel temperature always by touch. I mean, you can always record it, but if not, at least by touch. And then depth or the extent of jaundice and confirm any other findings which we have seen. Again, I keep telling about pulse oximeter again and again. So when we look at, it's all about what we want. It's not about trying to do every possible finding in newborn examination. I'm sure there are umpteen number of findings which you'll find out with every newborn baby, and some of which just cause a lot of anxiety. But the idea of a focused neonatal examination is really to find out if the baby can be in significant trouble, or the baby is normal, or does he have any danger signs at all. And that's all it's about. And given that we have to accept the reality that we are extremely busy, we will not land up examining 30 babies perfectly. So let's find out what needs to be found out and make sure that every baby is okay. So it's all about focusing. If you can, again, there are a lot of babies here, or maybe there is a tree. I just want you to find out the number of babies in this picture. And then again, try to put it. So if you're good enough, you'll probably pick up at least nine babies. So it's just about how we focus, and then it's about having a clear objective. So thank you very much for this opportunity and for the patience listening. Thank you.
Thank you, Professor Tiroumourougane. It was wonderful. I now understood focused newborn examination is all about a very comprehensive examination, that we do not miss anything in the baby, and ensuring that it is safe to go home with all things needed. But the way I understood before you started the topic was focused newborn thing, because in our SNCU, probably there are many times where simple focused, I will tell you the way I understood. I thought that the talk would go on. A child who comes with not passing stools, the postgraduate sends it back, on duty sends it back saying, it's still not 24 hours, come back if more than 24 hours